Good morning, ma'am, and my batchmates and my fellow juniors. Today I am presenting a seminar on IV fluids and its indications. I'll be briefly discussing about the various IV fluids and their indications and their compositions and in which specific conditions they are to be preferred than the other part. So first, what are the common indications include severe hypovolemia, sepsis, trauma, burn, perioperative volume loss. While infusing IV fluids, our objective is quickly administer a large fluid volume to restore circulatory volume, to stabilize hemodynamics of the patient, and to restore tissue perfusion and oxygen delivery. The timing and the rate of fluid administration in hypovolemic shock, our aim is to immediate action is required to prevent irreversible shock and multi-organ failure. Initial fluid resuscitation with 500 ml of crystalloid fluids with 130 to 154 milliequivalent of sodium within 15 minutes, and our aim is for 1 to 2 liters rapidly for hemodynamic stability. Close monitoring necessary, especially in high risk patients. Fluid resuscitation in sepsis, according to Surviving Sepsis Campaign 2021 recommendations, we should give at least 30 ml per kg of IV crystalloid fluids within 3 hours. We have to initiate this resuscitation as early as after obtaining blood for measuring lactate and blood cultures level, and complete within first 3 hours to improve the survival of the patient. Our initial target should be a mean arterial pressure of 65 mmHg and continuously access clinical parameters, hemodynamic status, and laboratory tests for additional fluid requirements. The fluid resuscitation in these patients is done in three phases. First is early salvage phase, that is within 24 hours. Our aim is to rapid fluid replacement, and second phase, that is optimization and stabilization phase, that is from 24 hours to 96 hours. Here we reduce the fluid volume based on the patient response, and after 96 hours it is last de-escalation phase, where we employ restrictive strategy for better outcomes. Type of fluids, we have crystalloids, in which we have normal saline, ringal lactate, plasmolite. Then we have colloids, in which we have albumin, hydroxyethyl starch, and dextran and gelatin. Then we have blood products, including pegged red blood cells. Fluid selection. The IV fluid distribute differently in different body compartments based on their composition, and intravascular volume expansion determines the efficacy in raising the blood pressure. Avoidance of 5% dextrose. The 5% dextrose has poor intravascular expansion, that is only 8% increase in intravascular volume with 5% dextrose, and it also causes osmotic diuresis, thus increasing the urine output and delaying the hydration status correction. And preference for normal saline and ringal lactate. Rapid intravascular expansion compared to 5% dextrose. They are also very safe in initial resuscitation in emergency with unknown glycemic status. They are inexpensive, readily available, non-infectious, and easy to store. Cautious against DNS, that is dextrose saline. It contains 5% dextrose and 0.9% NS. Faster infusion of these DNS may lead to hyperglycemia. Also, they also causes osmotic diuresis and increasing urine output. So, whenever there is fluid resuscitation is required, we should avoid dextrose containing fluids, that is D5 and DNS. Potency of colloids and blood products. Colloids can be natural or synthetic, and then we have the blood products. They rapidly rise the blood pressure during shock. The mechanism is simple, that they remain primarily in the intravascular compartment selectively, and thus selectively expanding the plasma volume. Benefits of colloids: they have lesser risk of pulmonary edema due to increased intravascular osmotic pressure and favoring the fluid movement into the vascular space. This is a schematic representation. In our body, we have 60% of fluid and 40% of dry weight. If we divide the 60% of fluid, it can be divided into 40 and 20. That is, the 40% of fluid remains in the intracellular compartment, while the rest 20 of fluid remains in the extracellular compartment. Out of this, 5% remains in the intravascular and 15% remains in the interstitial compartment. Now, what happens when we give different type of fluids? First, if we give 5% dextrose, this dextrose has 5% dextrose and then free water. This glucose will be utilized by the body. So what we have is a free water only. So it will be distributed evenly throughout all the compartments. So two-thirds of all the fluid, that is out of 1 liter, 666 ml will be given to intracellular compartment. Rest two-thirds, that is 333 ml, will be divided into the distributed in extracellular compartment. That is in extracellular compartment also 250 ml will be distributed inside the interstitial space, and only 83 ml will be redistributed in the intravascular compartment. So if we give 5% of dextrose 1 liter in a hope that we will increase the blood pressure of a patient, it will only increase intravascular fluid by only 83 ml. So dextrose containing fluids should be avoided. Then we have normal saline and ringal lactate. These normal saline and ringal lactate, they evenly distribute in the extracellular compartment and does not go into the intracellular compartment. So all the fluid 1 liter will be distributed in extracellular fluid. It will divided as per the 15:5 ratio. 750 ml will be distributed in extracellular interstitial space, and only and 250 ml will be in intravascular compound. So it is quite better than 5% dextrose. So if we give 1 liter of NS or RL, it will improve intravascular fluid expansion by 250 ml. Now, if what we give is colloids and blood, if we give colloids and blood products, they remain in the intravascular compartment only. So if we give 1 liter of fluid, it will increase intravascular expansion by 1 liter, 100%. So, so this is exactly what table shows. That is the 5% dextrose increases 83 ml of intravascular ml, RL and NS 250 ml, colloids 100%, and then we have another entity that is point N by 2. It has half of the concentration of normal saline, and it has volume expansion of 167 ml. That is less than NS and RL. Selection of IV fluid, the consideration must be given to the composition of the fluid, effectiveness, benefits, disadvantages in the different conditions, and we have options like crystalloids, colloids, and blood products. Crystalloid are regarded as the first line therapy. This includes normal saline, ringal lactate, and plasmalite. Why? Because they have advantage. The advantage as they are widely available, they widely used, readily available, and they have an effective volume expansion. Disadvantage is they have limited intravascular retention, because if we give fluid, they will not retain for longer. First, and then they have a risk of dilutional coagulopathy. Now, colloids are regarded as the second line therapy. This includes albumin, which is a natural colloid. Then we have hydroxyethyl starch, which is a synthetic colloid. Recommendation is natural colloids are preferred due to their safety status, and synthetic colloids are avoided due to harmful effects. Blood products are essential for severe hypovolemia, only related to any blood loss and severe anemia. And ensure compatibility while transfusing blood products, we have to ensure the compatibility and monitoring of the transfusion reactions. This is a composition of different IV fluids. First, what we have is a plasma. In plasma, we have sodium concentration of 136 to 145, then potassium 3.5 to 5, chloride we have 98 to 106. Then we have calcium in small quantities and magnesium, and the total osmolarity is almost about 285 to 295 millicoulomb. Then we have normal saline. In normal saline, we have only sodium and chloride. Sodium is 154 and chloride is also 154, and osmolarity is 308, somewhat equivalent to plasma but slightly higher side. Sodium is also higher and chloride is also higher. There is no other elements like calcium, magnesium, and potassium. Also, there is not low lactate and acetate. Acetate and lactates are the buffer which maintains the pH of the body while transfusing the fluid. So they do not have any buffer, and also they have only sodium and potassium, not any other thing. Then we have ringal lactate, plasmalite, and sterofindin. In ringal lactate, we have sodium 130 millicoulomb, potassium 4, chloride, and they have a buffer as a lactate, while the other two has a buffer in the form of acetate, and they have a plasma concentration osmolarity similar to that of what our body is. First, what we are talking about, isotonic saline, that is 0.9% NS. It is readily available, cost effective, and it is compatible with the co-transfusion of blood products and medications like ceftriaxone. Volume expansion, it contains 154 millicoulomb of sodium. It effectively expands the intravascular volume, corrects hypotension, and safer for specific conditions. That is, if we have a brain injury, it is preferred in brain injury because it has a low risk of cerebral edema due to osmolarity. It has slightly higher osmolarity than than our bodies. So a risk of cerebral edema as well as is reduced. So it is preferred in brain injury. Second is hypochloremic hypovolemic hyponatremia. Whenever there is hypovolemia associated with hyponatremia and hypochloremia, it is preferred. Third, it is metabolic alkalosis. It is glucose free, so it is suitable for scenarios when the glycemic status of the patient is unknown. Disadvantage, it is non-physiologic because the higher chloride concentration, that is 154 equivalent milliequivalent, is compared to human serum. It lacks the buffer to maintain the pH. And third, absence of any essential electrolytes like sodium, like potassium and calcium. Harmful effects is supraphysiologic chloride concentration leads to hyperchloremic acidosis. Second, it increases the risk of acute kidney injury. Third, hospital mortality and coagulopathy, hyperkalemia and interstitial fluid retention. It causes hypochloremic metabolic alkalosis because in NS what we have is only the chloride, which is more than the body's concentration, that is 154. Thus it inhibits the absorption of bicarb, thus resulting in the hyperchloremic metabolic acidosis. Second, it also causes acute kidney injury because hyperchloremia triggers vasoconstriction via tubuloglommular feedback mechanism, thus diminishing the renal perfusion and GFR and causing AKI. Third, use in hyperkalemia. Although normal saline does not contain any potassium and ringal lactate has potassium in it, in hyperkalemia we still prefer ringal lactate over normal saline. That it was previously used to be the myth that in hyperkalemia we should give sodium NS as compared to ringal lactate, but in hyperkalemia still ringal lactate is preferred because normal saline causes metabolic acidosis, which we have studied above. This acidosis causes intracellular potassium to come out of the cell, thus increasing the potassium levels. So in hyperkalemia, ringal lactate should be preferred over NS. Then balanced crystalloid. Rest the three of the crystalloid are termed together as balanced crystalloid. Why? Because balanced crystalloids are advanced resuscitation fluids with physiological composition and reduced risk of complication. Formulated closely resembles the electrolyte composition of the body, osmolality, and the pH of human plasma, and thus allow the safer administration for large volume without risking the electrolyte imbalance. Buffer capacity, they have bicarbonate precursors like lactate and acetate to prevent or correct metabolic acidosis and offer superior buffering compared to normal saline and aiding in maintaining the acid-base balance. Advantages, reduce risk of hyperchloremia, chloride content significantly lower as compared to normal saline, and thus reducing the incidence of hyperchloremic metabolic acidosis. Second, they have a strong ion difference which is close to what human plasma is, so also help in acid-base equilibrium. If we give these balanced crystalloids, what will be the effect of lactate levels? We have studied that they have acetate or lactate as a buffer. So if we give ringal lactate, what will it affect the serum lactate level? So there is a transient lactate elevation if infusion leads to only transient lactate elevation, not much, and does not significantly impact the lactate measurements or clinical interpretation. There was a misconception that during lactic acidosis, RL should not be given or RL aggravates the lactic acidosis. In RL, what we have is not lactic acidosis, only the lactate, which is in as a salt. So it acts as a buffer, not aggravating the lactic acidosis. Second, safety in hyperkalemia. So although it contains minimal amount of potassium, but it is preferred in hyperkalemia. And safety in neurological condition because they can aggravate the cerebral edema and so such conditions such as traumatic brain injury, we avoid using it, and they have a risk of increasing cerebral edema. In liver disorder, since lactate is metabolized mainly by the liver, so cautiously to be given during the in patients with severe liver disorders. In DKA, it is preferred over normal saline because first they have not any amount of dextrose. Second, they have a buffer, so have a ability to correct acidosis. So during DKA, they are preferred over normal saline. Potential complications, if they have given in large quantities, they may cause hyperlipidemia, but even when they are given in very excessive amount, metabolic alkalosis and hypotonia. Close monitoring required to prevent adverse event. Co-infusion consideration. It contains calcium and thus necessitates careful management during the co-infusion with blood products, which was not the case with the normal saline. And preventive measure essential to avoid complication arising from concurrent administration. So, what is which should be preferred? Saline versus Belen crystalloid. So, we have various trials: short trial, UNIS, McCluskey trial, Raghunathan trial, and SMART trial. And they have concluded is the current literature favors isotonic balanced crystalloid as preferred resuscitation fluid. So, balanced crystalloid fluids are preferred over plain normal saline, and these fluids have shown beneficial effect in metabolic acidosis, hyperchloremia when there is AKI. Ringal lactate suggested for various Ringal lactate has been suggested for various conditions including sepsis, trauma, surgical patients, and those at high risk of developing acute kidney injury. Difference between lactate and acetate buffer. Balanced crystalloids contain lactate and acetate as a buffer, and both has unique metabolic pathway. Acetate is more adaptable for the patient with severe liver dysfunction and shock as it is metabolized throughout the body. And physiological basis of limitations for ringal lactate is ringal lactate may not be suitable for patient with severe metabolic alkalosis, hypochloremia, and traumatic brain injury. Limitations include lower osmolality, sodium content, calcium presence, which can lead to complications. Then we have plasma light and its advantages. It mimics the human plasma with electrolyte content, osmolality, and pH. It contains acetate as a buffer, ensuring bicarbonate conversion even in the severe liver dysfunction. Osmolality, sodium concentration similar to plasma, avoiding the risk associated with imbalances. Now we shift our attention to colloids. We have discussed crystalloids. Now we come to the colloids. Colloids are regarded as the second line therapy and used for selective cases only. Potent resuscitation agent, colloids offer a rapid hemodynamic improvement even with small volumes over an extended period of time. Commercially, they are available as a natural colloid, which is albumin, and synthetic colloid, that is hydroxyethyl starch, dextran, gelatin. What colloids do है, they provide a greater volume expansion, faster volume expansion, and a prolonged volume expansion. Greater volume expansion is the colloid solution remain in the vascular space, resulting in a greater vascular expansion. Because they remain only in the vascular compartment, not any other compartment. So result in a greater volume expansion than compared to the crystalloids. Faster volume expansion, colloids statistically more effective in achieving resuscitative hemodynamic endpoints as compared to crystalloids, and prolonged volume expansion because of their longer half-life. Colloids have a longer intravascular half-life, resulting in prolonged circulation and better hemodynamic stability compared to crystalloids. They are potent. So what we have seen that they are more potent than crystalloids, but they have a selective use only. Colloids offer rapid hemodynamic improvement with small volumes, but their use is recommended selectively only because of their safety considerations. Commercially available includes albumin, HES, dextran, gelatins. Crystalloids versus colloid. So there is lack of superiority evidence. The evidence suggests there is no comparative superiority or significant benefits of colloids over crystalloids for resuscitation in non-specific and septic patients. Non-specific shock mein and septic shock mein, they do not have much more significant improvement in the patients, but they have more of a side effect, and their safety profile is not that yet good. So use of colloid should be only as an adjuvant to crystalloids. Colloids are used alongside with crystalloid when the patient requires large volume of fluids to expand intravascular volume. Second, hemodynamic stability. If colloids can be used as an aid to achieving hemodynamic stability with small volume fluid volume, and thus reducing the complication associated with crystalloids. So what we do is we use them adjuvant to colloids, so we can achieve hemodynamic stability early, and as also we do not require large volume, so that the risk of pulmonary edema is also reduced. Albumin is a safe but a costly option. Second line of agent, albumin is considered as a second line agent for fluid resuscitation, particularly when the patient are unresponsive to crystalloids or require substantial amount of crystalloids. Clinical consideration is they can be used as an adjuvant to crystalloids in various clinical scenarios where there is hypoalbuminemia, where there is septic shock, and specific medical conditions like spontaneous bacterial peritonitis seen in CLD and hepatorenal syndrome. Hydroxyethyl starch is not to be used anymore. Gelatin and dextran, they are also not recommended because of their safety profile. Then guidelines for blood transfusion in hypovolemic patients. In hypovolemic shock, due to massive blood loss or active bleeding, blood transfusion plays a crucial role in restoring hemodynamic stability alongside with fluid replacement and hemorrhage control. Transfusion threshold is if the patient, even if the patient is hemodynamically unstable and HB is low, then there is no doubt. But if the patient is hemodynamically stable, and even if the patient's HB is, and if the patient's HB is less than 7, then that is an indication of blood transfusion. In high risk patient, when there is a underlying sepsis, there is organ failure, and patient is going for any kind of surgery, even HB is less than 8 milligram per deciliter is an indication for blood transfusion. And if a patient is having ongoing bleeding, then first what we need to do is clinically assess and determine the need of blood transfusion based on the pulse, blood pressure, the rate of bleeding, and estimated blood loss, rather than solely relying on the serial HB levels. When we do a blood transfusion where we have a 1:1:1 protocol, that is, whenever we require large volume of blood, we need to give 1 peg RBC with 1 unit of plasma and 1 unit of platelet. And avoidance of liberal transfusion, that is, do not over transfuse patient, as even if you over transfuse the patient and any HB greater than 10 milligram per deciliter will not improve much oxygen delivery than around 10. Rather, it will, what will do is increase the blood viscosity and stasis, lead to impaired capillary circulation. So our aim is to maintain the HB level up to the 10, not beyond that.